We have another excellent issue this month, beginning with an article from Alzheimer's and Dementia on association of semaglutide with first-time diagnosis of Alzheimer's disease in patients with type 2 diabetes, then an article from Diabetes Care on increasing medication use and polypharmacy in people with type 2 diabetes, followed by another article from Diabetes Care on association of energy intake and dietary glycemic load in different time periods, different times of day, with cardiovascular disease mortality among adults with type 2 diabetes, then an article from Diabetes Care on comparative effectiveness of SGLT2 inhibitors for recurrent nephrolithiasis among patients with pre-existing nephrolithiasis or gout, and finally a discussion with the author of an article published in JAMA Internal Medicine on GLP-1 receptor agonists and the path to sustainable obesity care. Our first article this month is an incredibly exciting article titled Associations of Semaglutide with First-Time Diagnoses of Alzheimer's Disease in Patients with Type 2 Diabetes, published in the journal Alzheimer's and Dementia. Joining us to discuss this article, we're privileged to have Dr. George Perry, one of the authors. Dr. Perry is a professor and Sims Foundation Endowed Distinguished University Chair in Neurobiology in the Department of Neuroscience, Developmental and Regenerative Biology in the Department of Neuroscience, College of Sciences, the University of Texas at San Antonio. George, welcome to our podcast.
It's a great honor to be invited to comment about our article and its implications.
This is such an important article because Alzheimer's is important and people with diabetes are at greatly increased risk of developing Alzheimer's. Can you go over first some background to why you and your co-authors thought to look at this question?
It's an important question because there have been so many linkages between glucose metabolism, sugar metabolism, and Alzheimer's disease, heightened by something that was published in the journal I edit, coining of the idea that Alzheimer's is type 3 diabetes. Not saying it's diabetes, but differences in sugar utilization of the brain. And numerous studies of others have confirmed this type of approach. Further, some of the most exciting data that's come out of the Alzheimer field with implications that actually help people is that, in other words, things that you can do to actually reduce your chance of having the disease and maybe even have an impact after you've been diagnosed. And that is that exercise, diet, stress reduction, all of those things have a tremendous effect. And how it's most dramatized is the health disparities. African Americans and Hispanics have a higher risk with aging, and maybe threefold higher for African Americans. And this can be traced back by some studies to being mainly socioeconomically driven. And socioeconomic also plays into metabolic issues and also plays into the fact that there are a lot of things that people could do to reduce their fact of having Alzheimer's disease. So how does our study come into that? Here you have an agent that changes your metabolism and changes your risk significantly. And if you look at that in comparison with all of the media interest in the approaches of removing amyloid, where at best you find a change in slope, at best. And at worst, you find more cerebral bleeding and brain shrinkage, actually for all cases. In this case, you actually have benefit with no detriment. I think this study points to Alzheimer's disease being fundamentally like most other chronic conditions, whether it's heart disease or others, that it's a lifetime event.
Yeah, it really is fascinating. Over the last few years, we've begun to use the term brain health and really begun to think of the brain in a manner analogous to how we, for a long time, have thought about heart health, that there are all of these risk factors which in aggregate affect outcomes. Now, can you go over the methods used in this particular trial?
The methods are to be able to use extremely large data sets and to use the data mining to do virtual clinical trials. Now, are they the same as real clinical trials, random control? They aren't. But it's better than spending $1 billion, as was spent for lecanemab and Aduhelm. Each were $1.5 billion for clinical trials. To inform those trials by doing this type of in silico type trial with large data sets. Plus, there's a tremendous amount of power in these data sets. Doing studies where you're looking at, which have been proposed in Alzheimer's disease, studies where you examine, let's say, 50 and 60-year-old people and look at their changes of clinicians, clinical change over time, is tremendously non-realistic. If you're doing an invasive infusion, the cost of doing it, the time to wait for a change, most people that are not demented don't become demented. So you'd have to have really large data sets that are not realistic, as where an observational study from a pre-existing data set allows it to be done and allows to be the parameters for a real clinical trial.
Yeah, and the numbers in this trial, when I saw the methods section, blew me away. And there were over 1 million individuals in this data set who had type 2 diabetes and no prior Alzheimer's diagnosis that were followed for up to 3 years. Is that right?
Yes, and that wouldn't be practical for a real clinical trial.
So I guess in this data set, there were over 1 million people with type 2 diabetes, and essentially semaglutide was compared to a number of different diabetes agents in that large cohort. Can you tell us a bit about the results?
That's what's actually the most surprising result for me, is that the other agents had almost no effect,
And that's
especially metformin that's been proposed along this line. And in fact, my understanding is actually in clinical trials for Alzheimer's disease, had almost no effect.
that really is something. And then what was the effect of semaglutide compared to the other agents?
It reduced the onset of Alzheimer's disease by about 50%.
Which is
That's quite an effect.
That sure is. So reduce the development of Alzheimer's disease by about half. That's obviously a big deal. What do you see as real world clinical implications for this information?
I think it still requires further development. Number one, remember these were type 2 diabetics. Maybe it only works for type 2 diabetics because there isn't a similar data set for people that are non-diabetic, because the application of this drug has not been extensively used until recently for other people. That piece, and then also, is this advisable for patients for this type of treatment? There's still the question about all the side of Ozempic and other similar agents. Is that cost benefit ratio? I'm not talking about the cost of the drug, just the cost of the potential side effects and reduction of Alzheimer's disease. So I think it really needs to be confirmed in a random controlled trial types format.
Yeah, so this is hypothesis generating, but given the number of people in the trial, it is powerful information. Are there ongoing trials now of semaglutide in either mild cognitive impairment or early Alzheimer's or preventive trials? Are there any underway?
There are a couple that are sponsored by Novo, and those are really essential because the patients, for example, that are taking metformin may not be the same group of patients that are taking Ozempic or other types of drugs. And therefore, you could end out like there might be socioeconomic stratification, even though we tried correcting for it. And the best way to deal with that is to have a random controlled trial, which will find the results before long.
Dr. George Perry, thank you so much for sharing this information with us. This is an incredibly exciting area. Thanks.
It's been a pleasure and an honor too.
Our next article is from Diabetes Care, titled Increasing Medication Use and Polypharmacy in Type 2 Diabetes. Type 2 diabetes often coexists with other conditions and requires a lot of medicine. So the author's hypothesis was that polypharmacy among individuals with type 2 diabetes has increased over the last 20 years. They used a Danish national registry to look at this, looking at people with type 2 diabetes between the year 2000 and 2020, and they analyzed medication use and prevalence for varying degrees of polypharmacy, using as cutoffs greater than or equal to 5 or greater than or equal to 10 medications. First of all, the cohort of people with type 2 diabetes from 2000 to 2020 grew from 84,000 individuals to over 300,000 individuals. So this was looking at a lot of people. And then the number of daily medicines used per patient increased from a mean of 3.7 medicines, and these all had large standard deviations, not surprising. A mean of 3.7 medicines plus or minus 2.8, up to 5.3 medicines in 2020 with a standard deviation of 3. The lifetime risk of polypharmacy was large. 89% of people were exposed to greater than or equal to 5 medicines at some point, and 47% of people to greater than or equal to 10 medicines. John?
So, Neil, I find this to be very interesting and a very interesting thing to see how much things have changed during you and I's career in medicine. In this paper, in the widely accepted definition of polypharmacy is 5 medicines. CMS, it's actually 3 medicines in a patient over 18, so one of the things is the standards of where we're trying to control diseases, and not just the burgeoning increase in the number of people with diabetes. If you look at the best studies for hypertension, people are on 2.4 to 3.6 medicines. About 90% of the US population will develop hypertension. At least 80% of people will need more than 2 medicines. When we go way back, the only medicines were metformin, insulin, and sulfonylureas. Now we have a really broad palette of lots of different things that we can use. So I think one of the things is we really can't attain blood pressure control and diabetes control in 2025, really the way we need to, the way we've learned to do it, without using a bunch of medicines. So I think part of it might not necessarily be the diabetes medicines or the hypertension medicines. And the statins really have been shown, even in older people, to really decrease some cardiovascular risk. And so I think some of the other populations are when people start having more and more cognitive decline, when people are in more of a palliative state, can we get rid of things? We have people on PPIs forever and ever for whatever reason. People will complain about the medicines that you and I prescribe, but might take 12 things from the health food store. So partly it's that. And I think one of the other things is people do have a knowledge of how many pills they take a day. And if you can ever take something off, especially take something off that's on the beers list that's not safe, if you can use some combination antihypertensives, right? So if you have someone on a thiazide diuretic and an ACE or an ARB, and there's a combination for that, patient doesn't think they're taking 2 medicines, they think they're taking 1 medicine. So anytime we can do this, because if you look overall at adherence, the more medicines people take, the less likely they are to have adherence. Roughly 20% of hospitalizations in the United States can be related to non-adherence. So if we're trying to keep people out of the hospital and we want people to take their medicines, we have to be partners in trying to keep this list as tight as possible. Our next article is from Diabetes Care and looked at the association of energy intake and dietary glycemic load in different time periods with cardiovascular disease mortality among U.S. adults with type 2 diabetes. So this study looked at a cohort of over 2,900 adults with diabetes who were part of the U.S. National Health and Nutrition Survey that went from 2003 to 2014. And they looked at cardiovascular mortality that was obtained by linkage to the National Death Index through 2019. They looked at energy intake and glycemic load in the early morning, which would be from 6 to 8, late morning, which would be 8 to 11, late afternoon would be 11 to 6 p.m., evening, which would be 6 to midnight, and then overnight from midnight to 6 a.m. They derived from two 24-hour dietary recalls at baseline. Cox models were used to establish hazard ratios for cardiovascular mortality, which they adjusted for total energy intake, diet quality, socio-demographic and lifestyle characteristics, and medical conditions. At baseline, the study population, which was about 52% female and 62% non-Hispanic white, had a mean age of 57 years. The study participants were followed for 9.3 years. There were 190 cardiovascular deaths documented. Energy intake and glycemic load in late morning were inversely associated with cardiovascular mortality, with a hazard ratio of 0.9 and 0.86. In context, energy intake and glycemic load at night were positively associated with cardiovascular mortality, with hazard ratio of 1.22 and 1.44 respectively. Neil?
John, this is fascinating, and this article is an example of the emerging field of chrononutrition. The first, not study, but one of the early indications of chrononutrition was an old saying from medieval times, which was eat breakfast like a king, lunch like a prince, and dinner like a pauper, which is the exact opposite of what we tend to do with big dinners. And there's actually a wealth of evidence right now supporting that medieval saying. There was just an article recently in Diabetes Care that showed greater intake and glycemic load in late morning was associated with a lower risk of developing diabetes over time. And all this scientifically likely has to do with our circadian rhythm that, due to hormonal changes, has our glucose tolerance best late in the morning. There's actually another example. A study published in Diabetes Reviews recently looked at data from 9 clinical trials and found that people who were assigned to follow diets where they consumed the bulk of their calories earlier in the day lost more weight than people who did the reverse. Again, fits this old saying. And on a personal level, I hate this idea because I love snacking late at night. But it's also not entirely surprising. Again, this is one of many studies, and what's different about this study is that it links it not just to weight or diabetes, but actually to cardiovascular outcomes. Now, we have to acknowledge this study is not rock solid. They looked at middle of the night eating. There probably are other things going on, other potential confounding variables. If you're up in the middle of the night eating, you're also not sleeping. That said, this is something we're going to be hearing more about and certainly worth being aware of. Our next article is from the British Medical Journal and is titled Comparative Effectiveness of Sodium Glucose Transporter 2 Inhibitors, SGLT2s, for Recurrent Nephrolithiasis among patients with pre-existing nephrolithiasis or gout. This was a target trial emulation study just to start out. A target trial emulation study is basically that good old retrospective cohort study, but the difference is that ahead of time, the authors have to designate what are inclusion criteria that are strict and what things they are looking for so as to not have data mining go on. So in essence, you're looking back in time, you're saying, what would we be following people forward for and rigorously looking at? And that's why it's called an emulation trial. So What the authors sought to do here was emulate a target trial looking into the recurrence of kidney stones among patients who had pre-existing kidney stones and compare individuals who were on SGLT2s versus those who were on GLP-1s and DPP-4s to see, is there a difference in outcome with regard both to kidney stone formation, recurrent kidney stone formation, and gout. They looked at a Canadian population database from January 2014 to June 2022. There were over 20,000 patients who had nephrolithiasis and type 2 diabetes, including some who had gout as well at baseline. And as I said, they looked at initiation of an SGLT2 versus a GLP-1 versus DPP-4s. The primary outcome was recurrent kidney stones. There were 1,924 recurrent kidney stone events that occurred among the over 14,000 patients who used SGLT2 inhibitors, and that equated to 105 events per 1,000 person years, and that compared to GLP-1s, which was 156 events per 1,000 person years. That was an adjusted rate ratio of 0.67, or to say it a different way, a 33% decrease in the development of kidney stones. And the number needed to treat here was pretty impressive. It was a number needed to treat of 20. In those who had recent kidney stone, the number needed to treat was 5. When they compared it to a DPP-4, there was about a 27% decrease. There was also a lower rate of gout flare-ups in the SGLT2 group. John, your thoughts?
So, Neil, as more and more papers roll out about the pleomorphic effects of SGLT2s, it's really fascinating. And I wouldn't be surprised if we're sitting here talking about it in the future curing male pattern baldness, right? Which it does not. But yet another thing, and disparate things. So one is when you think about the thiazides, historically we thought that the thiazides decreased your chance of having a recurrent kidney stone. Actually, a very nice paper in New England Journal in 2023 actually disproved that. But that was what we did for a long time. But certainly when we think about giving people thiazides, and if it did help with kidney stones, it increased someone's risk of gout. If you looked at the ALLHAT trial, there was an increase in hyperuricemia. People got 25 milligrams of chlorothalidone, which is equivalent of 50 milligrams of hydrochlorothiazide. And this happens to do both. So when we look right now of medicines we can do to decrease the chance of someone having a recurrent kidney stone, there's not a whole lot. If someone has a uric acid stone, we could give them something like allopurinol. We can certainly do some dietary things. We can do some citrate, but there's not a whole lot right now to prevent kidney stones. And in this study, decreases it by about a third. Pretty impressive. I don't think at this point I would rush out to give this to someone who had kidney stones who does not have diabetes. But certainly falling into that category of that buy one, get one free. And certainly when we have people on a medicine, it's kind of part of that. Now, sulfonylureas are actually in the category of medicines that can increase your chance of having a kidney stone, just as you're thinking a little bit about the negative. And then certainly for gout, if you look at different hypertensives, the ARBs actually have a decreased chance of someone having some gout recurrence. Certainly the thiazides can increase that chance. So again, it wouldn't be a medicine that I would leap to, but certainly someone who has a history of gout, which is certainly a lot of our patients, it might be also one of these medicines in kind of the buy one, get one free thing that we might use to decrease their chance of having a recurrent episode of gout.
Joining us for our last discussion of this month's podcast is Dr. Jennifer Mané-Guler, who is an assistant professor at the Harvard Medical School and is in the Medical Practice Evaluation Center of Mass General. Dr. Guler is here to discuss her viewpoint, published in JAMA Internal Medicine, which is quite an achievement. And that viewpoint is titled GLP-1 Receptor Agonists and the Path to Sustainable Diabetes Care. Welcome, Jennifer.
Thank you so much for having me.
Clearly, this is an important topic. What led you to discuss the topic and then take the effort, and that effort is large, I know that, to write a viewpoint on it?
I'm actually serving as an expert to the World Health Organization for the development of guidelines for the GLP-1 receptor agonists globally, with a focus on obesity management in this case. I'm a technical expert to the World Health Organization, but I present this information as an independent academic and not on behalf of them. It's just inspired some of the thoughts I've had about this issue and how best to frame it. And I'm also trained as an HIV medicine physician. And one of the kind of challenges that is discussed frequently when one thinks about building real sustainable systems of obesity care that involve these, I would argue, transformational drugs or these very repressive agents, is how to maintain patients on them for a long time, and also how to think about people who either can't or don't want to stay on them forever, quote unquote, or for life. And so that was really what motivated the development of this viewpoint, was thinking about those issues and what's needed to really answer those questions in an evidence-based manner.
It's so important because clearly taking care of a lot of patients. And I'll just say, Jennifer, I do want to really thank you. I know you have laryngitis today.
Yes,
you woke up with it, and you're still pushing through with the podcast, and we do
Thank you.
appreciate that. Clearly, this is an important issue because a lot of the patients that I see, one of the first questions after asking, is it safe, is it effective, is how long am I going to have to stay on this? Am I going to have to be on this forever? And so this is clinically relevant from so many points of view. How do you frame this issue? What do you think are the main issues that we need to grapple with?
I think what's really needed is for us to think about a few different issues that one can summarize from all the literature that we're all writing about and reading about, is partly about the cardiovascular, kidney, and metabolic health effects of the GLP-1 receptor agonists, partly about their weight, their impact on body weight, which is important, of course, to many patients. And then thirdly, to think about their impact on body composition, skeletal muscle mass, and how people are able to maintain that, especially as they age and perhaps are on these medications. And so what's really needed in my sort of framing here in the viewpoint is just better evidence to support in whom, how, and most optimally we can help people who, for whatever reason, cannot stay on them forever. I think as a secondary issue, of course, is also the economic implications of potentially millions, even 1 billion people in the world who might qualify for them, being on them forever. And so what does it mean what does that mean for the way we build those systems of care and how we finance them? But that's a bigger sort of population level issue.
Yeah, I think one of the things that's fascinating is the way you frame this out, because the answer about off-ramping, and that's the term that you used, whether you need to stay on it forever, if you can come off of it, how, may be different for people if the goal is prevention of recurrent cardiovascular events, as it was in the SELECT trial, versus body weight, versus I love the fact that you included body composition, because the answers may be different for people when they're 75 or 80 years old.
Yeah, and I think honestly, I think you get right to the point, which is that the answer isn't, I don't believe, the same for everyone. And I totally think, I believe in obesity as a chronic relapsing disease. I think it needs chronic relapsing therapy. But I think we have to ask ourselves, just like we tailor strategies for many different chronic disease medications, hypertension medications, diabetes medications, goals for those diseases for patients across the lifespan and with different kinds of comorbidities that go along with them. I think the answer is I believe the evidence would show us that ultimately that answer is not the same for every patient in the case of the GLP-1s.
Yeah, I think that's such an important point, and that's not one that's been made very often. And that's what I thought was particularly interesting about the way that you're framing things. So, what do you see as needing to be done at this point?
I think that we need to move away from the idea that there's one monolithic answer to this question based on limited but still important information that we have so far. And we need to think about what I believe will ultimately probably be more of a publicly funded agenda for trials to test this question in many forms and different strategies in many forms for different populations. Those don't necessarily all need to be at the level of size and duration of follow-up necessarily as some of the very impressive trials such as Select that have been done to date. But I do think we need to be very serious about this question because ultimately we're going to offer our patients the best care by being able to answer it with evidence and having strategies that are kind of evidence, I believe, evidence-based to offer to people.
Yeah, and you went over in the viewpoint, and again, you covered a lot of information. I really refer our listeners to read the viewpoint. You covered a lot of information in a short amount of space, and you talked about three different things that might be ways to off ramp: a lower dose of a GLP-1, a choice among the older anti-obesity medicines, or lifestyle approaches.
Yeah, and I actually think the answer is probably going to be a combination of those in some patients based on existing smaller trials where lower doses are combined or older agents are combined with exercise, for instance. And we know that resistance training does seem to offer, especially aging patients, I think potentially some benefits, some meaningful benefits. I guess that, and also hear in the anecdotally that physicians and patients are at times being forced, often by supply or cost issues, to decrease dose and frequency of the GLP-1 receptor agonists. I think that is the first place we should be thinking about. Do we do that and pair with exercise? But I also think there are other groups of anti-obesity medications that when one thinks about, especially more of a weight maintenance framework, possibly a CKM health optimization framework, that older anti-obesity agents combined with exercise in particular may also offer a reasonable off-ramp for patients. And like any other chronic and relapsing disease, really hypertension is another one. One answer is not even necessarily the right answer for a single patient within their entire life course of experiencing that chronic disease. I could envision a world where people heal back and then later in their life they have some change and they have to go back up. But I do think that answering that question with evidence is really what will level up our care for patients who struggle with both obesity and diabetes, which is all the people we're taking care of.
Jennifer, when we started the discussion, I was afraid that we'd just be left with a kind of summary that we need more evidence. Good luck. But I think the way that you framed it actually provides us with a practical framework to approach things now until we have the evidence that we need. Am I understanding this correctly?
Yeah, I always think it's interesting that I believe that, or I hear a lot that patients and physicians, mostly, like I said, supply and cost, I would argue, are being forced to try some of these things. Whether we try them without the evidence is up to each of us as a patient provider team, I would say. But yes, I think there's a framework here that's more than even necessarily what we were able to fit into the article. And hopefully some of that will start to be backed by evidence.
Yeah, I think thank you so much for joining us. It allows us to think about how to organize our thoughts around this area. We certainly look forward to the evidence when it comes out. That'll be critically important. And we still make decisions together. And it's important together with patients about how to move forward with the evidence that we have. Dr. Jennifer Manny-Guler, thank you so much for joining us.
Thank you so much. Thanks for having me.
For more information and links to the articles that we discussed in this issue, just go to diabetesjournal.org. Until next month, keep listening
And keep learning.